Christian. I am executive director at Partners for Pediatric Vision. We have a treat for you today. We have Dr. Teresa Rosales. I also have on the call, we have Tori Sladen, who's the founder and director of special projects on our call, as well as Heather and Rosanna as well. I'm sure all of you guys know. And so we're, pleased to have Dr. Rosales, and I'm going to go ahead and pass it on to Tori, and she's going to go ahead and introduce.
Okay, this is off the top of my head, but we've been lucky enough to know Dr. Teresa Rosales for many, many years, and she has served a lot of our families over her career. Dr. Rosales is a pediatric ophthalmologist. Her practice was in Long Beach, Family Eye Medical, and she retired 4 years ago. 4 years ago. So I'm sure families were very heartbroken. I guess PPV feels lucky because we probably have more of Dr. Rosales' time than maybe we would if she was still practicing. But she is still involved at Harbor UCLA, training the fellows. Is that correct? In pediatric ophthalmology at Harbor UCLA, and doing a lot of other volunteer activities as well. And she's been gracious enough to present to our parent groups in English and Spanish. So she has a lot of knowledge, a lot of experience, and a beautiful way of presenting visual conditions and what can be done. And we're thrilled to have her here. Thank you, Dr. Rosales.
Thank you very much. All right. So we're ready to go ahead and start then?
Yes, please.
Okay. So this is a presentation that we've done in different parts previously. And when I finish, then I'll try to cover any questions that you might have. So write down your questions and either use, I don't see a hand raise or a chat on my screen, but if that's an option, we can take questions during the talk or at the end, either one.
Okay, and I'll monitor the chat and questions and stuff like that, and help you with that, so no worries.
Okay. Thank you. All right, so one of the things that I think you as parents probably known by now is that it's really important for your children to have pediatric vision exams. And it helps tremendously to have somebody who is a specialist in pediatric vision rather than the adult optometrist or ophthalmologist. Kids are not little adults, and examining them takes a special talent. It takes extra time. And each child is different, and especially our kids with special needs, they take more time. So the eye exams help us pick up things early and give us a chance to treat problems before they become really severe. The difference between an ophthalmologist and an optometrist gets blurred over time. The main difference is that an ophthalmologist is a medical doctor, an MD. Optometrists are ODs, or doctors of optometry. And so medical doctors go to medical school. We have about 4 years extra training than the optometrist does. But our practices overlap tremendously. Optometrists check vision, they can prescribe glasses, they can prescribe some medications. Main difference is that they don't do surgery. An ophthalmologist, the ones who do the surgery. So I think a little bit of anatomy is helpful. You don't need to remember all of these things, but it helps. My feeling is that it helps you understand where your child's eyes problem is, and it gives you a little better understanding of what the doctor's telling you when they tell you what's going on with your child. So we'll start at the front. The cornea is the clear part in front of your eye. You can't see the cornea unless there's disease there. Right behind the cornea is called the anterior chamber, and that's filled with fluid. Again, it's not something you can see. But behind that, there we go, is the pupil and the iris. So the pupil is an opening in the iris. And I might be able to show you some pictures later on where there are abnormalities of the pupil itself. The iris is the colored part of your eye. In patients who have albinism, their iris doesn't have that pigment, and that's part of the syndrome of albinism. Behind the pupil is the lens. Ordinarily, that's clear, but in patients who have cataracts, then there's going to be an opacity or a cloudiness to the lens. This is most common in older adults. And so most people who have children with cataracts don't know anybody else who has a child with cataracts. It's not that common. And the treatment is very different from the treatment for cataracts in adults. In adults, we make a little tiny opening in the cornea, pass an instrument through the pupil into the lens. They can suck out the lens and put in an artificial lens inside. With children, it's similar, but it's not exactly the same. The timing is very different. And often we don't put an intraocular lens in here, a plastic lens, to replace the lens and the focusing power of the eye. We often don't do that certainly in the babies, although the age is coming down more and more as we go along. When I first started training, we did not put intraocular lenses in the children at all. Then it became common to do it once they were at least 2, because the feeling was that the eye was probably close to adult size. And then you could get a better idea of what power lens to put inside the eye. The lens that we put in is similar to the prescription that's in your glasses. But children, as they're growing and their eye is changing and getting larger, the prescription that they would need in the glasses changes as they get older. So the debate was, what power do you put in this lens that goes inside the eye? Because we can't change it like we can the lens in a pair of glasses. So that was part of the reason why we didn't put intraocular lenses in children and young children. That's changing now, and people are putting in lenses in younger and younger children. As we go further back, here we go. This part in the center of the eye is called the vitreous humor, or the vitreous. And that's supposed to be clear. And there are a number of conditions where it's not clear. In adults, I'm sure you've heard of people complaining that they have floaters in their eyes. Well, floaters are little bits of the solid part lining the eye that has pulled off, and they're now floating in the vitreous that's supposed to be clear. And so we see these little spots floating by. They're incredibly annoying, but for the most part, usually are not a serious sign. So in the very back of the eye, lining the whole back of the eye, is the retina. And this is where the vision takes place. This is where the rods and the cones are that process our vision. And then that information is transferred into the optic nerve, which goes back to the brain. And then the other important part in the back of the eye is the macula. This is your area of central vision. So if there's any disease that involves the macula, we're going to have a significant problem with your visual acuity, or how well you can see the eye chart. So that's a very quick run through of the anatomy, and we can come back and look at that again if you have questions. So I understood that there was a question about coloboma. It's actually here in the slideshow, so we didn't know that we were going to have that question today, but the slides are here. And a coloboma just means that there's a defect. It can be in the pupil. Remember, that's the colored part. It can be in the eye. The pupil is the opening in the colored part of the eye. It can be in the iris. The ciliary body is this tissue back here right behind the lens. It can be in the lens, and it can be in the retina, which is again the part that's orange here. The choroid is the tissue behind the retina, or it can be in the optic nerve. So the most devastating colobomas are those that involve the optic nerve and the macula. This is, again, your central vision. So this is a picture of someone who has a keyhole pupil. It looks like the old-fashioned keyholes. And this is a coloboma in the iris. Now, we can't see from this picture, but there may be a coloboma in the lens as well. We can't see that except with a microscope. This is an example of a massive coloboma in the back of the eye. You can barely make out the optic nerve right here. This is definitely involving the macula, and it's causing what we're looking at, this white that we're looking at, is actually this lining here, the sclera, in the very back of the eye. So all of these layers of tissue are missing, and we're looking to the very back tissue of the eye. So this child would have very poor vision because it involves the optic nerve and the macula. Okay. So the accommodations for a coloboma depend on how significant it is. If it's just the iris, mostly that's just a, oops, excuse me, let me shut that off. Sorry. Oh, okay. It'll stop in just a second. So an iris coloboma is a cosmetic issue, but it doesn't usually cause any problems with vision. If it's a significant cosmetic issue, then we could use a custom contact lens that's painted so that it looks like it's just a round pupil. Sometimes it does, iris coloboma can cause problems with being sensitive to the light. And so wearing a custom contact lens that has the iris painted on it helps reduce the glare and helps with the cosmetic appearance. If the macula is involved, then the child's going to have very poor vision. If it's only in one eye, then usually there may not be anything that's needed to be done because they still have good vision in the other eye. If the coloboma is in both eyes, then of course, anything that we can do to help improve the remaining vision, such as somewhere that magnifier, adjusting the light so that there's not, and reducing the glare so that they're not affected by that, using sunglasses or visors or hats outdoors, and high contrast markers and templates may be helpful. So it really depends on how severe the involvement is as to what accommodations are necessary. So this is the normal retina. So when the doctor's looking with the handheld light or the one that goes on the head, the ophthalmoscope, this is the view that we get. So we see the normal optic nerve. These are the blood vessels, and that's what they're supposed to look like. And here's that area of central vision, the macula. And here in the very center is the foveola. The names aren't important, but just so you can have a little bit of an idea of what the anatomy is like and where the pathology might be in different diseases. So optic nerve hypoplasia, we've had several questions in the past about optic nerve hypoplasia. And again, it depends on how severe it is. If there's almost no optic nerve present at all, there's going to be severe loss of vision. And unfortunately, we can't do a transplant of the optic nerve and replace that. So the accommodations, the treatment would be trying to provide the best vision possible. Anytime when it's only one eye that has a poor vision, we really want those kids wearing protective glasses. We want to protect the vision in the remaining good eye. If it's in both eyes, then if there's a significant refractive error or a significant prescription, then by all means we give the glasses to the child and try to maximize what vision they do have. But optic nerve hypoplasia can be very mild and can appear to be just amblyopia. We treat with patching of the good eye, trying to improve the vision in the eye that's not seeing as well. And then we try to get as best vision as possible, but with mild optic nerve hypoplasia, there's going to be a limit. And I do remember one child who had 20/30 vision in the eye with the optic nerve hypoplasia and did very, very well. So that's at one end of the spectrum, and then the other end of the spectrum would be almost no optic nerve at all. Okay. And okay, we'll move on to albinism then. I know that there are a number of families who have children with albinism. Albinism's hereditary, and meaning that it runs in families. It's autosomal recessive, so both parents have to be carriers in order for the child to have albinism. And in general, they have very poor distance vision. Near vision is also affected, but they tend to do better at near than they do at distance. That's because albinism affects the cones more than the rods. Cones are the ones that are mostly in the optic nerve, or I'm sorry, in the macula, which is what I was showing you here. So in the peripheral retina, it's mostly rods, which are light and dark. That's what's affected in patients who have retinitis pigmentosa. But in albinism, the cones are more severely affected, and that's what is the cones are in the fovea and the macula. So the central vision is affected more in albinism. It also they also have no color vision because the cones are the color vision receptors. These children will have photophobia, meaning that they're sensitive to bright light. They have a lot of sensitivity to glare. They can have high prescriptions, high refractive error. Not sure about the central scotomas, but that makes sense because, of course, their central vision is affected more than the peripheral vision. They have nystagmus. Nystagmus is that wiggling movement of the eyes. And nystagmus can be either primary, meaning that nystagmus came first and the poor vision is secondary to that, or in albinism, the nystagmus is secondary to the poor vision. So that means that the children have poor vision, and the nystagmus is because we think maybe it's because they're searching, trying to find a clear spot where they can see things clearly. The reason that's important is that there are some surgeries for nystagmus for kids who have a face turn or a head turn to try to move that point where the nystagmus is less. We call it the null point. So that if they're turning their face so that they can see better and their eyes don't wiggle in this direction, we can operate on the eye muscles to move that null point to the more straight ahead position so they don't have that face turn. That doesn't work as well in albinism because their nystagmus isn't positional, it's because of the poor vision. So there have been all kinds of things looking at different procedures to try to reduce the nystagmus, thinking that that would improve the vision. And it might a little bit, but you're still dealing with the underlying problem that there's a problem with the cones, and we can't fix that. So one of the patients that I had really wanted to have the surgery to reduce the wiggling or the nystagmus of her eyes. And there was somebody in Orange County who was doing that surgery, but ultimately we realized that it wasn't going to solve the problem. It wasn't going to give her better vision, and that was her ultimate goal. So it's important to understand that the nystagmus is because of the poor vision, not in this case, it's not causing the poor vision. There can be a muscle imbalance or strabismus. And again, the treatment for that is the same as for any patient. If we can operate on the eye muscles and change the alignment of the eyes. Their eyes get tired after a lot of close or detailed work, and they usually have reduced depth perception. So the accommodations for albinism, especially in the classroom, the doctors can write a prescription to the school asking that they allow the child to wear a hat with a visor and sunglasses, even in the classroom if necessary. We recommend that they have their back to the window so that it reduces the glare. And they may need adaptive PE classes as well. Oh, I kind of jumped ahead and was talking about nystagmus already. So if the nystagmus is primary, then the wiggling does reduce their eye movement and does reduce their visual acuity. So if they have a null point, if they have a point where the nystagmus is calmer or not at all, then we can take the muscles off of the eye, reposition them so that we can get that null point into a more straight ahead position. The downside of that is that it doesn't work 100% of the time. And over time, there is often a little bit of a shift back towards their original null point. But it can improve, especially in kids who have a really significant face turn. It can make a big difference for them in terms of their lifestyle and the appearance. Amblyopia means that there's decreased vision in one eye in comparison to the other. It can be from a number of different causes. It can be from strabismus, where one eye is turning in or going out, so they're only using one eye and the other one is the one that's drifting. It can be from something physical causing a problem with one eye, like the coloboma can cause reduced vision. Optic nerve hypoplasia can cause reduced vision. And some of this can be amblyopia, meaning that they've just started to ignore that eye because they don't see as well as that eye. Or it can be a complete problem with their vision, and it's not amblyopia at all. But we try patching to see if we can improve the vision at all, and then try to maintain their best vision, whatever that happens to be. Because the amblyopia will lead to strabismus or a crossing or drifting of the eye. So we're trying to avoid secondary complications from this. Amblyopia will cause a reduction in the depth perception, a reduced visual field in the sense that with the eye, for example, if the eye is turning in, even if they still have some vision in the eye that's turning, they won't have the normal field that the rest of us have, which is about 120 degrees, 120 to 180 degrees. So if the eye's turning in, they'll lose some of that peripheral vision off to the one side. That's not a permanent loss. Whereas there are other disorders where the peripheral vision is permanently lost, and that's a reduction in the field, and that doesn't improve with any patching or with any surgery. For example, that would be in kids with retinitis pigmentosa. They're going to lose their peripheral field. And the same is true with glaucoma. So these are the eye muscles that I was talking about. When we do surgery to realign the eyes to make them straighter, the technical term is strabismus. When we do surgery, we don't open up the eye and we don't take the eye out. The opening is on the surface tissue, and then the muscles are here attached to the outside of the eye. So we have 6 extraocular muscles. Extraocular means they're outside the eye, and they're 2 vertical, 2 horizontal, and 2 that rotate the eye on its axis. So all of these muscles we can use to try to straighten out the eye if it's crossing or drifting. And then, as I said, in nystagmus, sometimes they take the muscles off, move the eye to correct the null point, not so much for strabismus in that situation. So esotropia is when the eye goes in. Exo is when it goes out. Hyper is one eye higher than the other. We don't usually talk about hypo, but hypo would mean the eye would be down. And strabismus can lead to amblyopia in the eye that's drifting, or the amblyopia could have been there first and that caused the drifting, one or the other. If the eyes are not straight, they're not going to have binocular vision, so they're not going to have good depth perception. Decreased, This can affect the eye-hand coordination, difficulty with scanning or tracking to a degree, depending on what the vision is in the better eye. And definitely issues with self-esteem when they're in grade school. And the treatment is to determine what the underlying cause is first. What's causing the drifting? Is it a primary problem? Is it secondary to amblyopia? What's causing that? And then treat the underlying problems. Okay, do we have any questions yet, Diane? Not yet? Okay, so I'll keep on going then. Myopia and hyperopia and astigmatism are all reasons why people need glasses, not just kids. Myopia tends to be something that comes on with over time. Generally, it shows up in the 8 to 10 age group. 3rd to 4th grade is real common. It's hereditary, tends to be autosomal recessive. If both of your parents are nearsighted, there's a good chance your kids are going to be nearsighted, or you're going to be nearsighted as well. So myopia is a technical term. Most people talk about being nearsighted. It means that you can see better up close than you can far away. And most of the time, glasses will treat the problem. They won't cure it, but they can treat it. I'm sure you've all heard of LASIK. And LASIK actually is a method where they operate on the cornea to change the shape of the cornea, to make it flatter, and that changes the nearsightedness and eliminates the need for glasses until you get to be older and need reading glasses. So it's not perfect, but it works really nicely if you don't tolerate contact lenses. Contact lenses work as well as the LASIK does, but you do have to put them in and take them out every day. There are conditions where they have extremely high myopia, so really strong prescription. And there are some congenital or hereditary disorders like Stickler syndrome where they can have very high myopia. Often children with Down syndrome have high myopia as well, and a significant astigmatism. So trying to treat children with special needs with glasses is a real challenge. We're fortunate that now there are a lot of frames that are designed for small children. There are a lot of frames that are designed for kids with Down syndrome. They tend to have a really flat little nose, and the normal frames won't stay up properly on a child. So now there are new frames that are designed specifically for kids, and often even for kids with Down syndrome or anybody who has a little flat bridge and they have nothing for the frame to perch on. They also have them where they can wrap around the ears or a strap across the back. They're almost rubber material so that they don't break. When I first started in practice, our optical shop spent hours repairing frames because the kids will take them and just go like this and break their glasses. So now frames are designed specifically for kids, keeping in mind that, yes, kids are really rough on their glasses. Also, all the lenses for children have to be polycarbonate, which is the shatterproof material. That's by law, so you don't have to worry about the lenses shattering anymore. Let's see. Hyperopia is usually the norm in children. Most kids are farsighted. It's not the opposite of nearsighted. It's a terrible term because they can see far away and they can see up close. Where it becomes an issue is if they have a strong prescription, they're highly hyperopic, then they have to focus in order to get the image clearly on the retina. And when we focus, our eyes start to converge a little bit. Well, if you have to accommodate or focus a lot because you have a strong prescription, your eyes are going to cross. And that's strabismus, and the crossing eye will become amblyopic or reduce vision if it's not being used. But the treatment is so easy. You put the glasses on, the right prescription, their eyes straighten out, vision gets better. Often we have to treat the amblyopia with patching, but it's treatable. Not only is it treatable, it's curable. And the good news is, as the kids grow, their farsightedness improves, so they may outgrow the need for the glasses altogether. So one cause of crossed eyes in young children, especially in the 2 to 4 age range, is a strong prescription. And the treatment is glasses. So I find that wonderful because we can do something and we know that the child's going to outgrow the whole problem, or most likely. And if they don't, when they're older, they can wear contacts. Okay, this is on CVI.
Rosales, before
Yes.
you do that, I wanted to, there's a couple questions that came in. And so this is from, I believe it was from Carla. And she had a question about the colobomas. She says, my daughter has a small coloboma in her left optic nerve.
Okay.
How does that affect her vision? Will she have glaucoma early on? What concerns should I ask about to her ophthalmologist? So questions to the ophthalmologist.
Okay. So good question. So she's saying that she has a small optic nerve in a small coloboma in the optic nerve. I'm assuming that means that it's not into the macula. So she should have the potential for close to normal vision in that eye. It could be anywhere from 20/25 to 20/60, I'm guessing, somewhere in that range. So that's good news. The child's still at risk for amblyopia or for crossing the strabismus, because it's possible that the vision won't be 20/20 in the eye with the coloboma. Even though the macula is not involved, the optic nerve is what carries all that information back to the brain. And if it's not fully normal, then there is a risk that there won't be perfect vision, and then therefore amblyopia, and therefore a possible crossed eye. So those are potential issues that could come up. So the treatment for that is that we patch the better eye, again, depending on the age and the visual acuity, 2 to 3 hours a day, trying to maintain the vision, whatever the good vision is, or the best corrected vision is in the eye with a coloboma. And without knowing all the details, I have to be pretty vague here. Again, depending on the best vision in the coloboma eye, maybe wearing glasses, either for the prescription or just for protection of the good eye. And as far as I know, there's no relationship between the coloboma and glaucoma. What you may be confusing or mixing up is that glaucoma does affect the optic nerve, and if it's severe, it can excavate the optic nerve from the pressure inside the eye, in the vitreous, pushing against the back of the eye. You start to lose tissue in the optic nerve. Coloboma is a defect from the very beginning. There was a developmental defect, and the optic nerve didn't develop completely. But that's totally different from glaucoma. So I don't think that there's a relationship between the two, and I don't think you need to worry about that. Down the road, is there a risk of retinal detachment? Without seeing your child's back of the eye, I would have a hard time answering that question. Depending on how big it is and the location, it might not be any risk at all. If the coloboma extends, losing my marker, if it extends into the retina, then there is a concern that at the edge, let me go back and see if I can find that picture of the coloboma. Here we go. At the edge of the defect here, so again, we're looking at the white is the sclera back here, and all these other layers are missing. But at the edge of that, there can be a late retinal detachment. It can start to separate. And the retina doctors, not the pediatric ophthalmologists usually, but the retina specialists may treat this by lasering the edge to cause a scar to get that retina to stay flat so it doesn't separate. The symptoms of a retinal detachment are usually a new onset of a blind spot. Usually in adults, especially, it shows up by flashes and floaters. Flashes are when the retina is separating from the back of the eye. Here we go. So if there's a defect in the retina and it starts to pull away from the back of the eye, then that can cause flashing lights. That's retinal stimulation. And we found that kids who are completely blind will be poking their eye all the time. And we think it's because it's causing retinal stimulation. So it's the same kind of process. It's the retina is being stimulated and that causes the flashing lights. The floaters are if that break or hole is where there's a blood vessel, it can cause that to start to bleed, and the floaters are blood vessels floating around in the gel that's supposed to be clear. So in this picture, if there were a break, say right here, you can see those two blood vessels crossing over the margin between the coloboma and the retina. If there were a break there and the retina became detached, it could cause some bleeding, and then you would get a new onset of floaters as well. So the flashing lights and the floaters are the two symptoms to look out for. The other symptom to worry about is if there was a cloud or a shadow or a curtain coming down over your vision. That would be also an indication that the retina was separating and detaching. The problem is that if you have a young child, they're not going to be able to tell you those things. And the only way to know if anything's going on in very young children is to have regular eye exams. And the eye doctor looks inside and will be able to tell if something's happening or not. But in the older child, they can verbalize those things.
And then if that did happen, if they do say that, you would want them to go into see an eye doctor's emergency room or anything like that, they need to get treatment. Would they need to
They
get
need to
treatment
be
as soon as
seen right
possible?
away. Yeah, the sooner the better. So if you call up an eye doctor's office and say, I have a new onset of flashes and floaters, that usually gets you in the same day. That's an indication that something serious is going on, like a retinal detachment, and they need to be seen. So those are the key words: new onset, flashes and floaters, or new onset of a curtain coming down over my vision. So the child has to be old enough to be able to express that.
And again, as we, I have a couple more questions for the parents. We can go ahead and turn off the recording but I just want to make the disclaimer, Dr. Rosales is not seeing your child. This is just informational